we move on to a particularly important and challenging area where precision, patience, and a lot of heart come together. To take us through pediatric onco-anesthesia and its challenges, we have Dr. Smitha Elizabeth, Professor, Department of Anaesthesia, CMC Vellore. To guide us through this session, we have Dr. Anita Shirley, Professor, Department of Anaesthesia, CMC Vellore, and Dr. Lenny Matthew, Senior Professor from the Department of Pediatric Oncology, CMC Vellore. May I request you all to kindly come forward.
I think before you start, I just want to say two words. So I think we had a very challenging session. Hope pediatric anesthesia is going to be less challenging than the adult complicated ones. But I want to say about 50% of the patients that we see are solid tumors and brain tumors and require some form of surgery. And a significant proportion of them have very challenging cases because of the location and also the extent of the tumor. We are very fortunate in our department to have a fantastic team of anesthetists who never make a fuss, and patients come out victoriously, and the surgeon's always flagging the flag for his hard work. But it's my pleasure to introduce Smitha to take us through the challenges that you face as you anesthetize all our patients. Over to you.
Thank you, ma'am. And thank you for this opportunity to talk on this topic. So my topic today is pediatric onco-anesthesia and its challenges. So I would like to start off with the challenges we have with pediatric anesthesia and then take you through onco-anesthesia per se. So we've all heard this famous quote that children are not miniature adults by Abraham Jacobi, the father of pediatrics. And why are they different? They are different because they are anatomically different, physiologically, pharmacologically, and psychologically different. There are so many differences that I can't really cover in this topic, but just to take you through some few differences from the airway. If you look at a child, the child has a larger tongue in proportion to the mouth. The epiglottis is much larger and floppier. The larynx is anterior and superior. The cricoid is the narrowest part of the airway. And even the tracheal bifurcation is much higher. The angle of bifurcation is different. And even 1 millimeter of edema in a child can cause a 16-fold increase in resistance to the airflow. All these things have its own anesthetic implications. And the very fact that the child has a bigger head compared to the rest of the body means that we need to put a shoulder roll for intubation, whereas in an adult we put a intubation pillow. And we need a lot of expertise when dealing with these children, as our intubation has to be very careful and very gentle. So for a novice who steps into the pediatric anesthesia, you might be overwhelmed because you have to choose among a large variety of different pediatric equipment, lot of formulae, and apologies to the PG who put this up on my operating room wall, and I just took a picture of it just to show how a lot of hard work goes in before a pediatric list. And if you chose medicine because you don't like maths, this is definitely a challenge for you. Now, starting with the procedures in pediatrics, behind this cute child with the chubby hands, a very difficult procedure, and your challenge for the day is awaiting you. And how difficult is this? You try hitting a needle onto a hair floating in a packet of fat and you get the idea. So sometimes the very first procedure we do in the morning might be a very challenging and difficult IV line. Now remember that there are so many physiologic differences in a child which have its own anesthetic implications and challenges. For example, an adult, compared to an adult, the respiratory frequency is different, the oxygen consumption is double, the oxygen reserves are less, and then all these implications, physiologic changes, have its own anesthetic implications and challenges. Remember that many of the, when the children are really small, the fatigue resistant fibers are very less, which means that they easily tire out. And the fact that they have a horizontal rib cage means that the deep breathing is restricted. So the higher respiratory rate and the higher oxygen consumption and the less oxygen reserves means that they can desaturate very, very fast. and of course, they have a higher vagal tone. So the moment you instrument the airway, they can go into bradycardia. And even hypoxia causes bradycardia. And the fact that the children's cardiac output is dependent on a heart rate, it makes it a very complicated and difficult scenario. Now, remember when you first step into pediatric anesthesia, there are a whole lot of vital signs that you have to get used to as normal, and that itself can be a big challenge. Now, there are a lot of physiologic differences between children and adults that affect the pharmacokinetics, from the immature blood-brain barrier to the higher metabolic rate to that higher total body water that they have, the immature hepatic metabolism, the immature renal function, and the differences in protein binding. All these things affect our pharmacokinetics. So whether it is absorption or distribution or excretion, everything or metabolism, everything is different in a child. And we need to keep this in our mind as we anesthetize these children. But what I would like to focus on a little bit is the psychological differences and implications for the anesthesiologist. This little baby and this teenager might be coming back to back on your list. But remember, one mistake I always see PGs doing is don't treat a 50 kg 10-year-old child like an adult, because they are different. They have their own psychological differences, and we need to be very sensitive when we anesthetize these children, and also be very sensitive to the parents. Now, I just put this picture up of this little child. Many PGs tell me that this child is so cheerful and playing with me, it will definitely come into theatre. But the morning of the surgery, you might see a very different child. And why is that happening? I would like you to look through the eyes of a child. Okay. So, in the theatre environment, which is very hostile, and us with our caps and masks and theatre gowns actually look very menacing. So we need to remember and be sensitive to this. And especially when I'm talking about this topic, like it's about onco-anesthesia. These are children who are going to come again and again to theatre. So we need to be very sensitive to these children and handle them with a lot of care and understanding. Now, if you look at the burden of disease in children, the WHO has said that more than 4 lakh children and adolescents develop cancer all over the world. So the burden of disease is actually quite high. And like ma'am said, the most common childhood tumors are a different set of tumors. They're not like adults. The leukemias, brain tumors, lymphomas, and solid organ tumors are the commonest kind of tumors. So I just would like to put this up because the hematological cancers are 30%, CNS tumors follow, and then the lymphomas. But if you look at the 0 to 4 year age group, they also have a lot of embryonal tumors like the neuroblastomas and nephroblastomas also coming. So the type of tumors are very different in a child, and that changes as they grow up. So onco-anesthesia in children. So when do we get involved as anesthesiologists? So unlike adults, we have to step in for their treatment from the beginning. That means even for their diagnosis, we have to come in for the imaging, for their biopsies, and then we need to come in when they start treatment, from the time they put in the central line, for their chemoport insertions, for RT, for the surgical excision of tumors, and for their ICU admissions. There are times when we have to step in for pain management as well. And even after they are healed and gone, sometimes they do come back to us because they need to get their chemoports out, and sometimes for the imaging for tumor surveillance. So all this means that there is a very high cumulative burden of anesthesia exposure over a relatively short period of time in all these children. Okay, so that is also something which is challenging. And as you went through all this, one of the most common places we encounter the children are the non-operating room areas, which have its own challenges. So this is a place where we have to consciously communicate to the parent team, to the parents, and explain the anesthetic choice and safety concerns before the procedure, during the procedure, and after the procedure. So I would like to just highlight the challenges of NORA, because this is a very risky area and we all should be aware of that. Now, there are different challenges. So the first challenge is challenges pertaining to the space. Now, many times it's an unfamiliar environment, It is geographically isolated away from a comfort zone, which is the main theatre. And we often have difficult access to the patients, especially in RT and MRI, and it's like remote monitoring. And of course, our workspaces are also limited. If you want to even intubate a child, you have to get the child out of the MRI room and come, so everything is different there. And the procedure rooms are also small, the environments are noisy, and there is inadequate lighting, and often there is electrical and magnetic interference. So there are a lot of things that you need to think about in this spaces, which are all challenges of its own. Now coming to the equipment and drugs. Often in these NORA areas, we have insufficient and limited supplies, and so it's very important as we go there to ensure this full resuscitation equipment and drugs before we even start the procedure. And remember, in these areas, if you need any kind of special equipment or any kind of special drug, you need to plan it well ahead and get it there. And coming to the staff, many times the technicians who are there are unfamiliar with our requirements. They don't really understand the requirements of the anesthesia team. There are times when I ask for a shoulder roll for a baby to intubate the child, and I get a shoulder roll which is bigger than the baby, because the radiographers there may not really understand what we are asking for. So all these are challenges when we work in these areas. And of course, if you need any help, we need to plan that also, because there is lack of senior and experienced help unless you request it. And even if you request it, there can be a delay in get that help arriving from the theatre. And so all these are again challenges. And when you come to the patients there, many times the patients we deal there are high-risk patients. They are ASA 3 or 4, and many times we do neonates also in all these NORA areas. The procedures also can be difficult, because many times they are new, complex. We don't even understand what exactly the interventional radiologist is doing, and so they can be invasive and risky procedures and in these NORA areas. So the NORA areas per se have their own set of challenges. Now coming to tumors, I would like to divide the challenges with tumors into the 4 M's so that we can easily remember them. Now the first M is about the medical management. Most of these children come after their chemotherapy and their RT, and they come with all the side effects of these things. Secondly, they have mass effect. The tumors per se might have its own mass effects and compressive effects on the vital structures. The third thing are the metabolic effects of these tumors. So, then the fourth thing are the metastatic effects of this tumor. So, whenever we deal with children with tumors, it's good to remember and go through these 4 effects that the tumors might have. Coming to chemotherapy drugs, they are cytotoxic to these rapidly dividing cells. So, they are great. They eradicate the cancer cells. But on that way, they also destroy the normal cells. And the sad thing is they can have potential toxicity to nearly every organ system in the body from head to toe. So we need to know what exactly is the toxicity with each of these chemotherapy drugs. So I have just put a few out there for us to remember. So remember then when the children have had chemotherapy with anthracyclines like doxorubicin, daunorubicin, they can have cardiomyopathy, congestive heart failure and arrhythmias. So it's important that whenever these children come, make sure they have had a preoperative cardiac evaluation with their ECG and echo. And cyclophosphamide can cause hemorrhagic cystitis, and many of these drugs cause bone marrow suppression. So bone marrow suppression with all these 3 cell lines, we need to look at it, and depending on which cell line is involved, we need to take steps. For example, if they come with leukopenia, we need to take strict infection control measures. And if they've had anemia, we need to arrange blood, and if the platelets are low, we need to arrange that also as they come for procedures. Another important drug to remember is bleomycin, which causes pneumonitis and pulmonary fibrosis. So what we should do as anesthetists is if they come, keep FiO2 as low as safely as possible, so that otherwise there can be oxygen-free radicals which can worsen the pulmonary toxicity. Then there are other drugs like cisplatin and carboplatin causing nephrotoxicity, neurotoxicity, and ototoxicity. Vincristine is something which can cause peripheral neuropathy. So in case they are on it, it's important to document the preoperative deficits. I just put this picture up because I like pictures and I like remembering the side effects from that. So all these nitrosoureas can cause neurotoxicity, and the bleomycin, as I told you, problems with the lung, and the doxorubicins and daunorubicins are cardiotoxic, and vincristins are things which cause peripheral neuropathy. The C there can be ototoxicity, and the cyclophosphomides are known to have cause hemorrhagic cystitis. Now, as I told you, many of the children who come to us when they are going through this cancer treatment can be immunocompromised. So that could be either because of the disease process, like leukemia, which causes bone marrow suppression, or because of the chemo and RT per se causing the bone marrow suppression. So they all come with reduced immune function. So it's important to treat these children very carefully with infection control measures. So it's important to have careful aseptic technique during invasive procedures, strict hand hygiene, maintaining the skin integrity, instrumenting the airway with care. And most of the time what we do in CB is the chemopods come as the first case of the day. And that is important so that they don't come after a child who has had an infection. And they can be perioperatively kind of isolated so that they don't get any infections from others. And another important thing is to look for mucositis and consider the potential airway complications. So oral mucositis is something which is quite common when children are undergoing chemoradiotherapy. So this occurs in up to 70% of children. So, and what we can see is this inflammation, ulceration and bleeding of the mucous membranes. So it's important to look for this mucositis before anesthesia. And the reason is that in case they have a low platelet and coagulopathy, the moment you do your instrumentation in the airway, you can end up with bleeding. So that is something we need to remember. Now remember that RT also has its own side effects. The ones which have implication for us are the thing is RT also affects the cancer cells and normal tissues. And they can cause fibrosis and stiffness of the soft tissue, and limited mouth opening and neck extension can result. Then they can also have mucosal fibrosis, subglottic edema, narrowing, and we can end up with difficult airway, which we need to look for whenever they have had RT before. RT also can affect the heart and the lungs, and we need to be aware of that. Now coming to the second M. So we said about medical management, and this is second M, which is the mass effects of tumors. So the notorious tumor which causes mass effects are these mediastinal masses. Among the different locations of mediastinal masses, the ones we need to be really worried about are the ones which are in the anterior mediastinum and the superior mediastinum, because these are the tumors which can actually compress on the airway, on our trachea, on our bronchus, on the superior vena cava and on our heart, and cause a lot of respiratory and cardiovascular compromise. Ironically, when I was preparing for this talk, this week I landed up with 2 mediastinal masses back to back, which some of them were horror stories, but it's important to know how to risk stratify these children and what are the danger signs we should look for. So if these children lie down and they have difficulty in breathing, or if they have cough, if they have stridor, if they have wheeze, if they have syncopal symptoms, and if they have upper body edema, facial swelling, or dilated upper body veins, then we are in trouble. Second set of red flags comes from the imaging. So if there is a reduction, 50 to 70% reduction in the tracheal cross-sectional area, if on imaging you see compression on the bronchus, on the carina, or if you can see compression on the great vessels and pericardial effusion, again all these are red flags. So most of the time it's the children with Hodgkin's lymphoma, non-Hodgkin's lymphoma and acute lymphocytic leukemia that have these mediastinal masses. So when these are the children you have to anesthetize, it's good to just look out for, do they have a mediastinal mass? If you have a chest X-ray, please look at it. So remember the 3 X-rays I showed you? So you need to stratify these children as they come into low risk, intermediate risk and high risk. So we have to look at what are the symptoms. Are they symptomatic? Secondly, we need to see if what are the radiographic findings that they have, and what are the echo findings that they have, and then plan your anesthesia technique. So many times, remember that first X-ray picture, those are very high risk kind of cases. If they come to us, most of the time they come to us because they need a tissue diagnosis. So the first step is to ask if that is really necessary. If you're going to get your diagnosis from a peripheral blood smear, let it be. And because once they have the chemotherapy and RT, then the tumors are going to shrink, and then it's going to be a little better for us to anesthetize them. But the second step would be to ask if this biopsy can be done under local anesthesia, and in an older child maybe some regional anesthesia, and maybe a bit of sedation with a drug like ketamine, because that does not suppress the airway reflexes, and it does not cause cardiovascular suppression. But having said that, whenever we step into this sedation for mediastinal tumors, you always need to have a backup plan, and remember there are so many things which can go wrong. You can end up with respiratory compromise, you can end up with a cardiovascular compromise, and we need to have steps to deal with it. Now, if at all you have to go ahead with anesthesia, a few simple principles are to, if possible, do an awake fiber optic intubation, but many times our children are not going to cooperate for that. You might have to try inhalational induction, because that is something you can easily switch off if you are getting into trouble. And the dictum is to maintain that spontaneous ventilation as far as possible, and avoid a muscle relaxant. And we need to always think about whether we will be able to intubate distal to the obstruction, or is the mask going to collapse on top of our tube. So it's good to have a rigid bronchoscope whenever we are dealing with these kind of children. And in very high risk cases, it is safest to have an elective cardiopulmonary bypass. So if these are the few precautions we take in mediastinal masses, and whenever there is a respiratory compromise or cardiovascular compromise, we need to know how to manage them before we take them up. Now we know that another huge set of tumors in children are CNS tumors, and many of them come with brain tumors, and many of them do have raised intracranial pressure. So in a younger child, you might just say restlessness and irritability. Don't see the typical nausea, vomiting, and headache that you see in adults. But whenever we do have a child like this, it is important for us to picture on which part of this curve this child is. So is an ICP normal? Is it increasing? And we need to take precautions to prevent a rise in ICP whenever we are anesthetizing them. Now, so I've finished 2 M's, and I'm going on to the third M. That is the metabolic effects of these tumors. So many times these children come to us with just electrolyte imbalance, and that is when the diagnosis is made of a tumor. So there is an entity called tumor lysis syndrome, which I'm going into. But before that, let me just tell you that these brain cancers and lymphomas sometimes have hormonal dysregulation. They can have SIADH. They can present with hyponatremia, and these children can come with seizures and encephalopathy. So that's an important thing we need to keep in our minds. And there are these tumors which have neuroendocrine effects and catecholamine release, and there is a whole set of paraneoplastic syndromes also in children. Now we'll just go into this entity called tumor lysis syndrome. So this happens in children who have a large tumor load like leukemias and lymphomas. The moment chemotherapy starts, these tumor cells get lysed, and when they get lysed, the intracellular components come out. So the notorious ones are potassium, which when potassium just rises, you can even go and it can cause a cardiac arrest or severe arrhythmias in the children. They can release a lot of nucleic acids, which increase uric acid and cause nephropathy. A lot of phosphorus also can be released, and this phosphorus usually goes and chelates with the calcium. And at the end, we have hypocalcemia and hypocalcemic seizures. The other thing that can be released are all the lactates and other metabolites causing metabolic acidosis. So why is this dangerous? It is actually a potentially fatal syndrome, and So as I told you, all these electrolyte imbalances can happen, and we can end up with cardiac arrhythmias, seizures, acidosis, renal impairment, and 21% mortality has been reported in these tumor lysis syndromes. So something that which I came across is there is a very important implication for an anesthetist, because remember, the steroids also can precipitate tumor lysis syndrome. And some of the literature said that even one single dose of dexamethasone has been known to cause this tumor lysis syndrome. I have not come across it ever, and I would like ma'am to tell me about it. But seeing that, I realized that giving dexamethasone as an antiemetic may not be safe in all groups of children, because it is known to cause this potentially fatal syndrome. So if there is tumor lysis syndrome, we need to treat them symptomatically, and depending on what electrolyte or acid-base balance has to be restored, has to be done. Now there is a whole set of paraneoplastic syndromes which we cannot really cover, but in children, most of the paraneoplastic syndromes happen with the nervous system and skin and rheumatologic system. So many of these are reported to be rare. But I would just like to mention one paraneoplastic syndrome which was supposedly rare, but we've been seeing it again and again for our neuroblastomas. That is the first line here, the opsoclonus myoclonus ataxia syndrome. So these are children with neuroblastomas, and what happens is the body responds to these neuroblastomas by trying to attack these cells and hosts an immune response, and ultimately it targets the cerebellar tissue or the nervous tissue, and these children come with all cerebellar signs. So they have opsoclonuses, dancing eyes or nystagmus, they have myoclonic jerks, and they have imbalance while walking. So they look like a child with a cerebellar disease. So as I had a case recently with this, and I looked up the literature, one thing I did realize is these children can have all their symptoms worsened if you give drugs like ketamine and etomidate. So it's important as you see these children and deal with these paraneoplastic syndromes. Many times we don't really know what exactly can go wrong, but it's important for us to go through literature and find out what are the anesthetic implications for each of these syndromes and treat them. Now coming to the fourth M, the metastatic effects. So one thing about children is, like I told you, the tumor profile is very different from that of an adult. So in adults mostly have epithelial cell kind of tumors. So the lumps and the bumps are easily picked up. But sadly in a child, the tumors are usually arise from deep-seated tissue. So you may not really see or feel the tumor that the child has. So that means that a large proportion of children, unfortunately, present with distant metastasis at the time of their diagnosis. So this is why we need to be aware that many of these children might have a metastasis, and we need to know where the metastasis is located as we make our anesthesia plan for our procedures. Okay, so putting all this into our minds, when we do preoperative assessment for these children, we need to do a full history and examination with special attention to the 4 M's, the medical management, the metabolic effects, the metastatic effects, and the mass effects of the tumors. Now, when we do a preoperative workup, we need to look at the full blood count, the biochemical profile, including electrolytes, the renal and liver function and coagulation profile. But remember, many times when they come to us in the NORA areas, not even a single investigation might have been done. So we need to really properly assess the children as they come to us, and we need to work with what we have. But if there is a preoperative imaging available, we need to look for the mass effect and metastasis. It's important to communicate between all the members of the multidisciplinary team, and it is very, very crucial to discuss with the surgeon so that we know the extent and duration of the planned procedure. And another very crucial point is clear communication with the parents, because we need to explain the anesthetic plan, we need to explain the risks, and we need to explain the instructions. So something very different for us as anesthetists is in the NORA areas, we are the only doctors the children and parents actually see. So we are the face of the physicians or the medical world, and we need to explain and communicate very clearly about what is going on. So that is something we are not used to, but we need to develop a good communication for this. So coming to the intraoperative period, the analgesia and anesthesia largely depends on where the tumor is located, what the surgical approach is, and we need to really understand the extent of the surgical dissection. And we can do induction and maintenance with IV or inhalation agents. In children, we need to have special care as we position them, because they are tiny and the skin is fragile, and we need to pay extra care, unlike even much more than an adult. And we also need to maintain the temperature and have an optimal management. Blood and blood products also have to be given as indicated. And we need to know whether we can give regional safely in these children or not. Now, one study I just came across is that there is a lot of literature about the fact that volatile anesthetics actually promote cancer cell dissemination, and then they can alter the tumor microenvironments and cause recurrence. And in some of the studies done in adults actually say that TIVA and NSAIDs in the perioperative period may be beneficial, and perioperative blood transfusion can be associated with harm. But the fact is, all these studies have been done in adults, and they cannot actually be extrapolated to the pediatric population. One, because they, as I told you, there are so many differences pharmacologically, physiologically, anatomically, and even the whole tumor profile is very different in a child. And the fact that they, unlike adults, they keep coming to us. So these findings should not be extrapolated to the pediatric population, and unless we do a large high quality randomized control trial, we will not be able to definitely say whether we should move from inhalation anesthesia to TIVA. So postoperative period should have a smooth extubation, and you need to have a proper analgesia, ensure hemodynamic stability, and shift to HD or ICU if you need to monitor them postoperatively. So one thing which I found very encouraging as I went through this is more than 80% of children actually can be cured with the treatment, and it is our duty to reduce the emotional stress of the multiple painful procedures and surgeries. And it's very important as far as possible to provide a calm and non-threatening environment preoperatively and effectively manage the postoperative complications, especially pain. And this way we can help the smile, keep the smile stay on these children and be a part of the healing environment in these children. Thank you.
Thank you, Dr. Smitha, for the very comprehensive talk on the challenges faced in pediatric onco child. Because we are almost come to the end of the session, so I think we can take a couple of questions. Are there any questions from the audience? You covered most of the aspects of the periop care. I just want to touch on very important thing when it comes to very small children, especially children less than 2 years. We all know the implication of a prolonged or repeated anesthetic on the developing brain. So that is something what we need to keep in mind. So this is not a surgery what you can postpone for for the child to grow up after some time. But what we can do, at least what we can try to do is combine procedures as much as possible. Say, for example, a child is coming for an imaging and the radiologist requesting for a biopsy at the same setting. We try to accommodate, even though there is no slot, we try to combine procedures. Similarly, when they come for chemoport insertion, if they want an LP also, we try to combine that together so that we limit the time of or the multiple anesthetic exposures. Now, apart from, but if the child is coming for actual, surgical procedure, now that the duration of it, the extension, how extensive it's going to be, that is not under our control. So the duration is going to be longer, and, so what we can do from the anesthesia side to ensure that you can minimize the effect of the anesthetic on the developing brain is try to keep the parameters what we can control, or which can also affect the neurodevelopment as much as possible. You can control it. Say, for example, you prevent hypoxia. You ensure that your ventilation is fine and prevent hypocarbia. Make sure your temperature management is fine so that the child is normothermic at the end of the time. Ensure that you plan your analgesics so that your child is not in pain. So by controlling these factors, which definitely we can modify, you are trying to give a better outcome for the child, because definitely malignancy surgery cannot wait. Dr. Lenny, you want to add on anything?
Actually, that was a very good talk. I just wanted to say a few things. One is about, in an acute setup, especially when they're present with a mediastinal mass, the most important thing to look at is the electrolytes. Because if a child has got most of those children are in tumor lysis even without us starting any treatment. So be aware of that. The second thing is, any tumor arising from the facial area, it is good to have a discussion with you guys before the surgeons reach theatre, and you don't have a shock of your life seeing what is to be done. So I want to welcome you to attend our MDTs on Thursday for difficult cases, so we can have meaningful discussion on what happens, what's going to happen in theatre.
So tumor lysis syndrome is commonly seen, ma'am?
So mediastinal masses, usually it's secondary to T lymphoblastic lymphoma, leukemia, or a Hodgkin's or a Burkitt. So it's mainly the lymphoblastic leukemias which are prone to have. But if there is any blast in the peripheral blood, we would rather do that than do a biopsy. So it's mainly for those ones. But be aware to look for any signs of tumor lysis. And also among the paraneoplastic syndrome, hypercalcemia. Those are all the ones which will trouble you when patients under anesthesia. Thank you.
The disconnect between the teams, the parent team, the intervention radiologist or the biopsy team, the surgical oncology team, with respect to chemo port placement and things like that, and the anesthetic team. And then the decision and the coordination when the child has to come. I think you rightly pointed out our effort to minimize the number of anesthetic exposures. But many a times we are caught unawares. Every major organization has this problem, and she rightly said, we become the ultimate face of the medical world to the parent and the kid. And we get a sorry figure because we really don't know what the planning has gone on beyond. And more often than not, who communicates? It's usually the junior most person in the other teams who communicates with us. And so I think we need to highlight all these aspects. And things go nice, and suddenly they spring a surprise. You need something else. You need a CSF tap. You need intrathecal drugs and so on. So I'm sure all major organizations have this problem. But it's a right approach that we need to highlight the aspects and what are the risks and the issues. Thank you. It's a fantastic presentation.
For reminding us that children are not just small adults, especially in anesthesia. It is indeed a field that demands both skill and sensitivity. Thank you, Dr. Anita and Dr. Lenny, for lending us your expertise. I request Dr. Anita and Dr. Lenny to kindly give away the memento to Dr. Smitha. Thank you, ma'am.